Okay, so we're going to talk about psychopharmacology now, and the reason I want to talk about this now is because around us, and this is happening so fast that we really don't realize what's going on. We have really come to the end of the road in terms of current practice of psychopharmacology. We have, for the last 20 years or so, since about the introduction of Prozac in 1987, been living in something that people have called the antidepressant era, where antidepressants were universally dispensed, really, for a variety of ills, many of which had nothing to do with a diagnosis or a presenting complaint of depression, and universally thought to be effective for the management of those conditions. That turns out not to be true. But the assumptions that we went into this in the 1980s, that we could identify a common biological foundation, and there was a determined biological final common pathway in depression and other serious mental illness, and that was the underlying ethos, that was our core precept. That's not true. And I'm going to tell you in a little bit about why that is not true. But we are facing that reality more and more today, and we look now not at what the ultimate biological answer might be, but the fact that we have really bumped up against, in many instances, the limits to the biological model, biological explanations of mental disorders. Okay. In the 1980s, there was a sociologist by the name of Helen Hacker. Some of you may have studied a little bit of her work in some of your courses. She very famously said that serotonin, and this was in the after the introduction of Prozac, of course, and the serotonin reuptake inhibitors. She said that serotonin was the phlogiston of the 20th century. And if you remember your history of science, phlogiston was this unknown element that created fire in the 18th and 17th century. People didn't know about the chemistry of combustion and the physics of combustion, and so they thought there had to be this thing out there that caused things to erupt into flames. They didn't realize the contribution of oxygen to combustion, so they called this thing phlogiston, and it was good for everything. And in a similar sense, we thought that serotonin was the answer to everything in the 1980s. It turns out very much not to be the case. So we are increasingly questioning about whether or not there is going to be this final biological answer to depression. And the answer, by the way, is not. I can guarantee you that no matter how hard we look and no matter how fine a microscope we apply to this, we are never going to come up with a single common biological denominator for depression. It doesn't exist. And I think that increasingly we can ask those same questions about other common severe mental illnesses. So we questioned the basic assumptions. That's a big deal. Then there are some more pragmatic things that are going on that we have to pay attention to. One of them is the fact that patents on most of the commonly prescribed psychopharmacological agents are expiring. Okay? All of the new generation of antidepressants, it started with Prozac in the 1980s, all of those patents are essentially gone. There are a few that linger out there, but most of them are entirely gone. What does that mean? That means that I can get that medicine in a generic form. I don't have to go out and look for Prozac. I can get generic fluoxetine at a fraction of the price that I would pay for a branded medication. That means that there's less impetus for pharmaceutical manufacturing companies to promote these treatments for mental disorders. And that's a significant variable, because the creation of demand by pharmaceutical manufacturing companies is a very significant component in determining the use of that agent. And we create demand, interestingly enough, not just by educating physicians and other prescribers, but by telling the public that they need to be taking this particular medication. When the economics change and there's not that much money made by promoting a particular drug, utilization of that drug always drops. And it's very, very predictable. When you stop promoting a drug, When a drug loses its champion, utilization of that drug diminishes. Okay? Particularly in the case of things like antidepressants, because with antidepressants, their efficacy is not as great as they might be for certain other medications. So if you have a drug that's of rather questionable efficacy, it's really been propelled into the marketplace by a lot of activity on the part of pharmaceutical manufacturing firms. But then when people come back and say, gee, maybe this isn't quite as effective as we had initially been led to believe, that really affects how people think about those drugs, how people use them, and the rates at which they're used. Okay? There are two other pragmatic issues that really are affecting the modern, today's practice of psychopharmacology. One of them has to do with this class of agents called second-generation antipsychotics, things like risperidone or quetiapine. The new antipsychotic agents that replaced the standards that existed from the 50s until the late 1990s, really. Things like haloperidol, Haldol, or chlorpromazine, Thorazine, similar medications. One truism in psychopharmacology has been that with every new generation of agents, the newer generation has a couple of characteristics. It tends to be much better tolerated by patients, and it tends to be a heck of a lot safer. Let's use the example of the tricyclic antidepressants. Introduced in the 1950s, mainstay of treatment for depression until Prozac and similar medications came along in the late 1980s. They were no more effective or less effective than any antidepressant we have today. Efficacy has remained unchanged. It is the same. But patients didn't like them because you had to take them several times a day. They gave you terrible anticholinergic side effects, dry mouth, weight gain, constipation, blurred vision, and the like. And they were really hard on patients to take. The third thing they didn't like, that doctors didn't like about them, was that they were extraordinarily lethal in overdose. Two pills of most common tricyclic antidepressants are enough to kill an infant or a toddler. Okay? So if they pick up something off the floor that's been dropped on the floor, 2 pills will kill an infant or a toddler. A 10-day supply is sufficient to kill an adult. So you can imagine that when we were giving these medications to patients who were already at risk for suicide, physicians were extremely reluctant to hand these out willy-nilly. Then we came up with Prozac, very, very safe in overdose. So its use expanded. But this is characteristic of all of these classes of agents. They become better tolerated by patients. We come up with drugs that patients can take more easily. They don't have to take them 3 times a day. They can take them once. And they're safer, except for second-generation antipsychotics. What was a big problem with the first-generation antipsychotics, haloperidol, Haldol, and others? What was the big worry that clinicians had about their use? There was one major side effect that scared the dickens out of everybody, as well it should have. Tardive dyskinesia, okay, which is a permanent neuromuscular deficit that people get after taking medications for a long period of time, various other factors that led to it, but a fairly significant portion of anybody who had to take a first-generation antipsychotic over an extended period of time was at high risk for developing these neuromuscular deficits called tardive dyskinesia. You would think, if it were an antidepressant, we would look for another drug that wouldn't have that side effect, but would still have some antidepressant efficacy or antipsychotic efficacy. And people have looked for a long time. They haven't found one. Every modern antipsychotic drug has a risk of tardive dyskinesia, just like the earlier ones did. These also have a series of other side effects that the earlier antipsychotics didn't have to such a great extent. But the bottom line is, these drugs are no more effective than the first antipsychotics introduced in the 1950s. And at making them different from other classes of medications, they are no safer. They're poorly tolerated. They are no safer, and they're no more effective than the earlier antipsychotics. People are recognizing this now because we spend a huge amount of money on these drugs. In some instances, 2/3 of a state's mental health budget goes to the prescription of second-generation antipsychotics. They're very, very expensive. $5, $7, $10 a dose or more, whereas you can get a dose of haloperidol now for about a nickel, literally. So policymakers are starting to look at this and say, wait a minute, they're not safer, they're not more effective, they cost a heck of a lot more. What are we doing here? So that's a big change that we're having to face. Very, very similarly, newer anticonvulsants. What do we use anticonvulsants for in mental health treatment? Mood stabilization, right? Bipolar disorder. Severe irritability or mood lability. These drugs are now being used. What was a classic drug for bipolar disorder or mood instability? No, classically, the one that first out of the blocks. Lithium, right. Okay, no, Abilify is actually an antipsychotic, not a mood stabilizer, but there are lots of them out there. Again, we're having the same questions about these very expensive new compounds, but no safer or more effective than the earlier compounds were.